زي ما احنا متعودين. And this is the first case. It says coronal CT scan of the brain without contrast. Okay, and this may represent, as you have said, an intracerebral hematoma, but if you look carefully and you see this is not the usual location of hemorrhage, and also the hemorrhage is usually not cortical based, and sometimes is located in the temporoparietal area. And the edema around the hemorrhage is not that evident, as you can see in this case. So I would prefer the diagnosis of the hemorrhagic infarction, especially if you see that the superior sagittal sinus is showing the classic delta sign, or the what looks like a filling defect, even if you are not injecting contrast material. So the diagnosis is the hemorrhagic infarction, and I'm sorry, this was a contrast enhanced CT, not a pre-contrast scan. So the delta sign is evident, as you can see here. This is the final diagnosis is superior sagittal sinus thrombosis and the hemorrhagic infarction. Next case. GBM, yes, and this is glioblastoma multiforme, and there is now a new entity which is known as leptomeningeal glioma, which in which you can see that there is some extension of the neoplastic tissue reaching the surface of the brain and the leptomeninges, which are also enhancing between the tumor and the cortex of the brain. Actually, the diagnosis of glioma is right, and the glioblastoma multiforme is okay. But I would like you to know that whenever you see that type of tumor extending, you remember bronchogenic carcinoma with dural tail, this is almost similar to it, where you can see some neoplastic enhancing tissue going through the leptomeninges to reach the surface of the brain. Next case. This is T1, and this is T2, and this is gradient image. Yes, and actually these are multiple cavernomas showing the classic appearance in the T2 weighted image as well as in the gradient image. And you remember that gradient images are much more sensitive than the conventional MRI sequences for detection of more cavernomas that cannot be seen in the T1 and T2 weighted images. And this is a good example where you can see a lesion here, another one here, another one here, and also this lesion, which is also not seen in the images. These are multiple cavernomas, and you know that the multiplicity of cavernomas is very common in familial cases. This is a female patient, 45 years old, with a mass in the posterior fossa, and this mass is enhancing, heterogeneously enhancing. Mendymoma, acoustic neuroma. Okay, if you look carefully here and you see a big mass at the cerebellopontine angle with some erosive changes in the adjacent temporal bone, and the extension inside the internal auditory canal. The most common space occupying lesion in this particular area is acoustic neuroma. Then you have to say first that this is acoustic neuroma. Whenever you are asked about the differential diagnosis, and you are going to say lymphoma and metastasis. Lymphoma can occur in the leptomeninges and also in the dura and can erode the adjacent bone. And metastasis also can occur at the cerebellopontine angle and destroy the adjacent temporal bone. But you should remember, or you should answer the commonest, which is, of course, acoustic neuroma. And acoustic neuroma, whenever it reaches big size, it can erode the vitreous and can erode the internal auditory canal and even can extend into the supratentorial area. Next case. Yes, very good answer. And this is Moya disease, and I know that you know that Moya disease is almost usually bilateral, but sometimes you got the disease affecting one side, as you can see here. And one of the clues for the diagnosis of this Moya disease is the minute vessels seen in the basal ganglia area corresponding to the perforator arteries. And you remember also that this Moya disease may be complicated by ischemic insults. And the answer is right. This is Moya disease. Next case is a male 50 years old with vertigo and vomiting, multiple surgeries and gamma knife treatment for posterior fossa tumors. And this is MRI axial T1 with contrast, and sagittal and coronal with contrast, and this is sagittal T2 weighted image. No, actually you got, if you look carefully and you see some lesions that appear cystic with an enhancing mural nodule, and also another one here which is cystic with an enhancing mural nodule. The most common cystic tumor with an enhancing mural nodule in the posterior fossa is pilocytic astrocytoma. But you know that pilocytic astrocytoma is a pediatric tumor. And whenever you see a lesion that is similar to pilocytic astrocytoma in adults, and also you confirm your diagnosis by multiplicity, since the pilocytic astrocytoma is not multiple, but the hemangioblastoma can be multiple in the posterior fossa as well as in the upper, in the spinal cord. Then whenever you see these lesions, your diagnosis is hemangioblastoma, and because they are multiple, you consider the possibility of von Hippel-Lindau syndrome. And I hope you remember that I mentioned in my lectures that if you see a lesion, a cystic lesion with an enhancing mural nodule, and a solid one in the same area, then you consider that this lesion is also cystic with an enhancing mural nodule, but the nodule has occupied most of the cystic space. Then you consider these multiple hemangioblastomas, and you consider the diagnosis of von Hippel-Lindau syndrome. Next case is a male patient or male child, 2 years old, with abnormal signal at the basal ganglia, as you can see here. This is axial T2 weighted images, and this is axial flare, axial T1, sorry. Okay, I think that whenever you see these lesions, you consider one of the lesions that affected the basal ganglia. And this age group is very likely for the diagnosis of Leigh syndrome. And you know that Leigh syndrome is a mitochondrial disease that mainly affects the basal ganglia and the brainstem. Rarely it can cause white matter abnormalities. Its other name is subacute necrotizing encephalomyelopathy, and this is the age of presentation, which is usually around the 2 years of age. Then this mitochondrial disease affects many of the systems in the body, like the heart, the eye, the liver, the kidney, and many of the structures. But in the brain, it has a very characteristic distribution, which is abnormal signal in the brain stem, especially affecting the periaqueductal gray matter, and also lesions in the basal ganglia, especially in the putamen and the globus pallidus. Also, it affects the caudate nuclei and the thalami. Next case is brain without contrast, and this is also without contrast, and this is CT angiography. Yes, and this is subarachnoid hemorrhage, and this hemorrhage is located in the circummesencephalic cistern and the prepontine cistern, as well as in the ambient cistern on both sides. The angiography is provided so that you can identify the cause of bleeding, which is most likely an aneurysm. But if you look carefully, especially in the posterior circulation, you cannot see any aneurysmal dilatation. Then you may have this entity, which is known as the circummesencephalic or perimesencephalic is spontaneous hemorrhage. You know, the most common cause of subarachnoid hemorrhage, whenever you are asked in the exam, is trauma. Then other causes like rupture of an intracranial aneurysm, bleeding coagulopathies, and spontaneously without any evident cause. Next case is an MRI of the posterior fossa. This is axial T2 and this is axial T1 after contrast injection, and you got a big lesion which affects part of the cerebellum and part of the brainstem. Metastasis. First, before we mention metastasis, and you should specify the primary lesion that can arise here, especially if you do not have in the history or in the images some findings that can lead you to say that these are metastases, but nothing in the history and nothing in the images. Then you start first by the primary lesion, which is located in this area. If you look carefully, then you see that the lesion is mainly affecting the bones as well as the middle cerebellar peduncle and extends in the cerebellar hemisphere on the left side. The fourth ventricle is compressed and the ambient cistern is effaced, meaning that this is an intraaxial lesion. Then you are in the differential diagnosis between either a tumor in the cerebellum that has extended into the brainstem, or the opposite. You have a brainstem tumor that affected the cerebellum. And this is more common than a tumor in the cerebellum that can extend into the brainstem. Then we agree that this is a brainstem tumor, and of course, the first is a brainstem glioma that has extended brainstem glioma that has extended through the middle cerebellar peduncle into the cerebellar hemisphere. Then this case, you have a big lesion in the left frontoparietal area. This lesion is of intermediate signal and T2 and the flare with homogeneous enhancement and diffusion restriction. And these are the possibilities: meningioma, lymphoma, glioblastoma, metastasis, and abscess. Yes, the answer is right. This is lymphoma because this is not meningioma because of the absence of the dural base. Lymphoma has the diffusion restriction, as you all know, with homogeneous enhancement, periventricular location. Glioblastoma is the heterogeneous enhancing lesion. Abscess is a marginally enhancing lesion. Metastasis needs another point in the history or in the films. The diagnosis is lymphoma. Then, lymphoma represents about 4% of the primary brain tumors, and 90% of these lesions are located in the supratentorial area. And the symptoms are similar to any brain tumor, like headache and seizures, and usually affects the old age in the males greater than females. And the frequency of lymphoma in especially in immune compromised patients, and lymphoma can cross the midline through the corpus callosum. Also butterfly glioma can do this, but glioma does not show diffusion restriction, and the glioma shows heterogeneous enhancement. The differential diagnosis of lymphoma lies in the glioblastoma multiforme, which is heterogeneously enhanced, the abscess, which is marginally enhanced with central restricted diffusion, toxoplasma, which occurs in the basal ganglia, progressive multifocal leukoencephalopathy, and this is not an enhancing lesion. Next case is an MRI of the cerebellum. Then this is flare, and this is T2, and this is diffusion, and this is ADC. No, pilocytic astrocytoma, left or right? What do you think? Where is the cerebellum which is bad? Left or right? No. The right cerebellum is that cerebellum which is diseased. You got low signal in the flare, meaning that you are dealing with fluid, and low signal, high signal in the T2, and this confirms the possibility of fluid. Then in the diffusion weighted images, you got free diffusion, and in the ADC as well, and this is cerebellar encephalomalacia. The left cerebellar hemisphere is good, nothing at all in the left cerebellar hemisphere, but the right cerebellar hemisphere is that one which is diseased. And this is a female patient, 66 years old, with progressive gait imbalance and fatigue. Axial T2, axial T1 with contrast, and MR spectroscopy. Glioma, which side? Left or right? Oh, bilateral. This is bilateral thalamic gliomas. You got mass in the left thalamus and another mass in the right thalamus. The masses, whenever they are not enhancing, then you are dealing with the diffuse type of astrocytoma. And you know that these are not ischemic or metabolic or because of the spectroscopy. There is a very high peak of choline, and the peak of N-acetyl aspartate is depressed, and also you got some lipids and lactate. This is bilateral thalamic gliomas. This is a case of MRI T2 and T1 post contrast, and you got a lesion in the occipital lobe on the left side. Yes, and right answer. This is BXA or pleomorphic xanthoastrocytoma, because you got a cystic lesion with an enhancing mural nodule supratentorial, and the nodule is peripherally located on the surface of the brain, whether this surface is medial or lateral, as you remember. Next case, and this is a child 3 years old with headache, seizures, vomiting, and inability to walk. This is T2, and this is T2, and this is coronal T1 post contrast. Um, I hope don't say metastasis unless you have a positive history of primary malignancy, or you have a finding in the images that can support your diagnosis. Never say that these are metastases unless one of these two prerequisites are available. Then, if you look here and you see a child 3 years old and a mass which is centered on the occipital horn of the ventricle corresponding to the site of the choroid plexus, then you are suspecting a choroid plexus at the papilloma. But whenever you see extensive brain edema around the lesion, you know that this lesion has invaded the ventricular wall and extended into the brain parenchyma, which means that you are dealing with choroid plexus carcinoma. Carcinoma of the choroid plexus is seen in the usual age of choroid plexus papilloma. It has the same location as the choroid plexus papilloma, and also the same pattern of enhancement, then the same pattern of location, I mean. But the only difference is you got extension of the tumor outside the ventricle. How can you know this? By the presence of extensive perifocal brain edema around the lesion. Of course, the choroid plexus papilloma is not surrounded by edema. It is isolated from the brain surface by the ventricular wall. Next case is a female child with headache and seizures. This is T1, and this is T2, and this is T1 post contrast. How can you know that the lesion is intraventricular? Okay, I uh, I uh, I explained in details in my lecture how can you judge that the lesion is inside the ventricle. And I mentioned that by the nature of the lesion and by the shape of the lesion and by absence of perifocal edema, and the lesion, whenever it grows, it will have the same configuration of the ventricle. The only difficulty here is that you can see brain edema around the lesion. But what helps you to predict that diagnosis is the age of the patient and the location of the tumor, which corresponds to the site of the choroid plexus. But if this lesion is contained within the ventricle, you will see a dilated ventricle around it. But whenever the tumor has extended beyond the ventricular wall, the ventricle will collapse because of the edematous brain tissue around. Okay. Then, what do you think of this case with a child with headache and seizures? And you mentioned that this is an abscess, but if you look carefully, you see that the abscess in the T2 weighted image will contain fluid or pus, and this pus will be of bright signal, and it would be also of less bright, of less hypodense, hypointense in the T1 weighted images. Also, whenever you look for the diffusion weighted images, then you can see that there is no restricted diffusion. And this is the spectroscope, which can be helpful in exclusion of a brain tumor. There is no metabolites, only lipids and lactate. Then what do you think? This is not GBM because of the spectroscope. Once more, never say metastasis without an evidence to support your diagnosis. Yes, the answer of fungal abscess is good. You know that fungal and tuberculous abscesses contain caseous material, and this caseous material do not cause diffusion restriction. And this MR spectroscopy is supportive that this is not a neoplastic lesion because there is no choline nor any of the known metabolites except for the lipids and the lactate. Then if you say that this is fungal abscess, you are right. If you say that this is a tuberculous abscess with a solid caseation, you are right. This is very important, of course, because the tuberculous abscesses as well as the fungal abscesses may pass into these forms. Number one, the tuberculoma, which is hypointense in the T1, hyperintense in the T2, marginal enhancement, and no restricted diffusion. Tuberculoma with solid caseation, no restricted diffusion. Tuberculoma with liquid caseation, and then you got peripheral diffusion restriction. Next case is a female patient, 50 years old, with a lesion that is based to the dura, is homogeneously enhanced, and it looks as if it is infiltrating the calvarium, because you see a high signal and enhancement in the bluic bones. And if you look carefully, you see also an extra osseous soft tissue component outside the calvarium. Then, if you suspected that this is a meningioma, it should be atypical or aggressive or meningioma grade 3, for example. And if you need an alternative diagnosis, this is a angioperocytoma. And at that time, if you are asked about the differential diagnosis, you say lymphoma and metastasis. This is the sequence of events, and do not provide the diagnosis of metastasis as the first possibility if you do not have a support for this. If you know that this patient had a breast cancer, then the diagnosis is metastasis. If you do not have that, do not know that the patient had a breast cancer, then you go for the diagnosis by this way. I identify a lesion that is homogeneously enhanced based to the dura, infiltrating the calvarium with extracranial extension. First possibility is an aggressive meningioma. Second possibility is a hemangiopericytoma. Third possibility is a lymphoma. Fourth possibility is metastasis. Okay. This is a female patient, 30 years old, with a recent history of lumbar puncture. Yes, the answer is right. This history is diagnostic, of course. If you see diffuse leptomeningeal enhancement, and you can see here with a positive history of lumbar puncture or CSF leak, then you can easily diagnose the possibility of intracranial hypotension. Of course, intracranial hypotension has many other diagnostic stigmata that can be seen frequently, especially in the sagittal images. One of these findings is the low-lying position of the cerebellar tonsils. The second one is the decreased bone to mammillary distance. You see, this is the bones and this is the mammillary body. There is a known distance between both. But in cases of hypotension, you see that the mammillary body is approaching the top of the bones. Number three is flattening of the anterior bones. You see the anterior bones is normally convex, but in cases of hypotension, the anterior bones is flat. And effacement of the suprasellar cistern, you can appreciate that the corpus is intimately related to the superior aspect of the pituitary gland, and this is not the case in normal conditions. These are the findings of intracranial hypotension. Other findings include rounding of the transverse sinus, or distension and rounding of the transverse sinus, and the possibility of the presence of subdural hematomas, either unilateral or bilateral. And there are some of the measurements that you can help you in the diagnosis. The mammillary, or the bone to mammillary distance should be greater than 5.5 millimeter in normal conditions. And the bone to mesencephalic angle, this is the angle. And the mesencephalon is the midbrain, and you draw a line, mamas, or tangential to the anterior aspect of the midbrain, and another line at the top of the bones, and you measure the angle in between. And this angle, if if it is less than 50 degrees, is suggestive of intracranial hypotension. Of course, the angle between the vein of Galen and the transverse sinus is also one of the measurements, but this is the most important one. And this patient is known to have lymphoma, and this is flare image, and this is T1 with contrast. How can you diagnose this as meningitis, and you have a positive history of lymphoma? What do you think? And if it is meningitis, then you should also say that I am dealing with a case of leptomeningeal enhancement due to lymphoma. But inflammatory meningitis can be included in whenever you are asked about the differential diagnosis. But if you know that the patient had lymphoma and you have leptomeningeal enhancement, you know that this is lymphoma. And you remember the differential diagnosis of leptomeningeal enhancement is one of four: TB, sarcoid, lymphoma, and the metastasis. Okay, and this is T1, T2, diffusion, and ADC. Yes, this is a straightforward case of a brain abscess. You got a lesion which is in the occipital lobe, low signal in the T1, high signal in the T2, surrounded by perifocal brain edema with significant diffusion restriction, as you see in the diffusion weighted images and ADC. Then this is the difference between an abscess and the glioblastoma multiforme. In the glioblastoma multiforme, you got significant enhancement of the wall with no evidence of diffusion restriction. Actually, you might see some diffusion restriction in the periphery or the infiltrative margin of the tumor, but inside the lesion, you do not see diffusion restriction. And this case is T1, T flare, T2, and the contrast enhancement. If you are asking me about the history, and this is Caesars and Phoebe. Yes, and this is herpes encephalitis because of the typical location in the temporal lobe. Whenever you diagnose herpes, you should carefully examine the opposite side because herpes is frequently a bilateral lesion, but here is unilateral pathology. This is the child with CT brain with intravenous contrast. Yes, and the answer is right. This is ventriculitis or ependymitis. You got dilatation of the ventricles with enhancement of ependymal enhancement. And if you look carefully in the occipital holes, then you can see some fluid levels which represented the debris and pus located posteriorly because it is more heavy than the CSF. This is a classic appearance of ventriculitis. This patient, 23 years old, and this image was obtained 7 hours after a horse kick to his head. Yes, no, this is not subdural, it's an epidural hemorrhage with active bleeding or what is known as the swirl sign. Whenever you see an acute hemorrhage with some low densities inside the hematoma, you know that this is a hyper acute blood, and this sign is known as the swirl sign. Then you should mention this in the report to know that this hematoma or the bleeding is active, and it should be the patient should be the hematoma should be evacuated because the bleeding is continuous. Then these are three images: axial, sagittal, and coronal, after contrast with a big specific lesion in the left frontal lobe. Okay. You start first by the primary lesion in this location. Number one is aggressive meningioma or high-grade meningioma. Number two, hemangiopericytoma. Number three, lymphoma. Number four, metastasis. And this was a typical meningioma. And you know, meningioma grade 3 and hemangiopericytoma are now included in the same group. This patient is on warfarin, which is an anticoagulant, you know, is fell off a ladder. No, this is not an intraparenchymal hematoma. This is actually a subdural hematoma on the surface of the brain, and this is hemorrhage on the surface of the tentorium. Then this is not the appearance of an intracerebral hemorrhage. It's vague with no definitive margin or surrounding perifocal edema or so. Then if you look carefully here and you see that this is subdural blood, and you know the subdural blood can extend on into the falx and also can extend into the tentorium, then this is the right answer is an acute subdural hemorrhage with extension into the tentorium and the falx. Actually, you see that the medial part of the temporal lobe is extensively displaced to the opposite side, and this may lead you to diagnose the uncal herniation as well. Or it's safe to say that this patient had an impending transtentorial herniation because of the obliteration of the quadrigeminal cistern. Okay, this patient with scissors and the post-contrast T1 MR images at the level of the ventricles and high up. No, this is not a meningioma, of course. And actually, you see the gyral pattern of contrast enhancement, which is typical of Sturge-Weber syndrome. The other supportive finding, which is enlargement and the enhancement of the ipsilateral choroid plexus. Actually, in this T1 weighted MR images, you cannot see the classic calcification, but if you have the gradient or the susceptibility weighted images, you can see. You depend on other signs like gyral pattern of enhancement and the prominence of the choroid plexus. This is a 39 years old female, flare, diffusion, ADC, flare, diffusion, ADC, two levels in the flare images, then two levels in the diffusion and the ADC. Yes, right. This is an MS because you got multiple white matter periventricular subependymal lesions, and these lesions frequently do not cause diffusion restriction. But you know that it's reported in the literature that large lesions may produce diffusion restriction, and some of the literature may say that you can depend on diffusion restriction for judgment of the activity of the disease without the need to inject contrast material. This is maybe one of the indications that these big lesions with restricted diffusion may be active. The answer is MS, and these are the post-contrast images, and you can see very faint enhancement in this lesion, and also here the same. This patient with middle ear infection and semi-comatose. Yes, and this is subdural emboyema, right? And the answer is right. You got collection in the subdural space with meningeal enhancement, and this collection is of bright signal in the flare with marginal enhancement post contrast and the diffusion restriction. You got bright signal in the diffusion weighted image and the dark signal in the ADC. Okay. Here you see this is T1 and this is flare, and this is T1 post contrast with the MR spectroscopy. Yes, this is low-grade glioma, but I have mentioned that if you see that this glioma is affecting more than three lobes or more, you need to consider the possibility of gliomatosis cerebri or infiltrating glioma. And here you see that part of the frontal lobe is affected, part of the temporal lobe is affected, the thalamus is affected, and the contralateral thalamus is affected. Then you say that this is the gliomatosis cerebri or infiltrating glioma. This patient had seizures with T1 weighted image and T2 and the T1 post contrast. No, this is not meningioma, although you can include in the differential diagnosis. You know that the meningioma is a mass with it does not grow along the inner table of the skull usually, but some types of meningiomas may produce a similar appearance, but you should think of another possibility like lymphoma, and then this is a good possibility, leptomeningeal lymphoma, leptomeningeal metastasis, and the sarcoid. You should also include sarcoid in if you see Blake-like. You remember in the CNS infection, I have said that one of the differential diagnoses of sarcoid is meningioma, and actually meningioma do not produce very dark signal in the T2 weighted images. And the supportive signs for the diagnosis of sarcoid is the clinical history, leptomeningeal enhancement, and other organ affection, like especially in the chest, because more than 90% of the patients with neurosarcoidosis have a chest findings. And I have also mentioned that leptomeningeal enhancement has four differential diagnoses, which are the sarcoid and TB, lymphoma, and metastasis. Whether these are leptomeningeal or pachymeningeal enhancement, the diagnosis is almost the same. This patient had confusion, delirium, and hallucinations. I don't know what is alcoholic encephalopathy, but this is central pontine myelinolysis. You see an abnormal signal in the central part of the bones, and then you can see here affecting most of the brain stem, and this is osmotic demyelination or central pontine myelinolysis, and alcohol is one of the causes, of course, and the rapid correction of hyponatremia, one of the predisposing issues for the development of central pontine and extrapontine myelinolysis. In this disease, you got abnormal signal in the brainstem, in the thalami, in the geniculate nuclei, in the posterior fossa, and the mammillary bodies, hippocampus, corpus callosum, anterior commissure, internal and external capsule. And one of the characteristic appearances is the Mexican heart, which may be seen classically in the brainstem. And you remember I have mentioned in the literature that if the disease is acute, then you got diffusion restriction in the lesion. If the disease is not acute, then you got diffusion free. This patient had history of sudden rise of blood pressure during dialysis. Breast is right, and then this is posterior reversible encephalopathy syndrome, which is a brain edema due to vasospasm due to sudden increase in the blood pressure, which is classically occurring in the posterior aspects of the brain, in the posterior fossa and the occipital lobes, and may reach the parietal lobes, and it is reversible. From its name, it is reversible and it does not produce diffusion restriction. This patient on hemodialysis for 6 years with cognitive decline. You feel that this is the difficult case? Yes, and this is just a brain atrophy, nothing else. This is brain atrophic changes. The ventricles are prominent, the cortical sulci are prominent, nothing abnormal in the brain parenchyma. Next case is a patient with renal transplant, recently developed nausea and vomiting, leg and arm weakness, seizures and headaches. The answer is easy, I know. Yes, right, and this is the classic appearance of lymphoma, classic history, and the classic imaging findings. Periventricular homogeneously enhanced lesions with diffusion restriction in an immune compromised patient due to the transplant. Then the possibility of lymphoma is very good. This patient is hypertensive, presented by bilateral visual loss, stupor, weakness of the upper limbs. And this is a pre-contrast and this is post-contrast. No answer. What you see here is multiple hypodense lesions in the brain, and these lesions do not enhance Some of the lesions are cortical based, and other lesions are located between the territories of the vascular markings. And this is a good example of multiple watershed infarctions, either due to increase in the blood pressure or due to decrease in the blood pressure. These are multiple watershed infarctions. Thank you very much, and good.